So the topic is anesthesia for laparoscopic abdominal procedures, clinical pearls for safe conduct. I know it's Perithal is a place where laparoscopic surgery is extensively done. So I hope there will be a mutual discussion and it will be useful for me too also. So to start with, I don't have any conflict of interest, nor I am not supported by any financial support, and I am not going to speak for any product also. So laparoscopic surgery is always termed as minimally invasive by the most of the medical professionals and to a certain extent lay public also, but it's a highly misnomer, because as anesthesiologists we know that it is highly invasive to the physiology and biochemistry of the patient, and nowadays it is done to the extent that it is carried out from neonates to older and sicker patients, and there is a learning curve for a new surgeon also. So invariably the anesthesiologist has to take the blunt of all these things. So another thing is that unlike the open surgery, the complications tend to be more insidious. Yet in most instances, the post-operative benefits outweigh the intraoperative physiological changes. But the message I want to carry is that it is a highly invasive to the patient, and as anesthesiologists, we cannot take things lightly. So we have to know thoroughly the patient factors. Before accepting for laparoscopic procedures, you should have a thorough cardiovascular examination of the patient and understanding the physiological and biochemical alterations the patient is likely to have during procedures, because and the associated risk associated with the procedure, that also you should know, because many of the procedures may extend for 3 to 5 hours, and during the procedure, patient may have to be in the steep head down position or head up position, and so you have to know the duration of surgery to assess the patient completely. So coming briefly about intra-abdominal pressure, it's a steady pressure within the closed abdominal cavity, the normal being 0 to 5 millimeters of mercury, and anything more than 12 to 14 millimeters of mercury can compromise venous return. But in our healthy patients, or as a grade 1 or 2 patient, it's easily compensated. And the initial flow they said is 4 to 6 liters per minute, and the maintenance is 2 to 400 ml per minute. The anesthesiologist, in addition to the altered physiological and neurohumoral factors, has to be vigilant from the trochar insertion itself. There are instances where there are reported incidents of injury to aorta or bowel, and sometimes the gas can go in a wrong place, as in extensive subcutaneous emphysema. You can I've shown the picture also, and you can see that an increase in ATCO2 in spite of adequate controlled ventilation and reduced breath sounds, and any increased PaCO2 EtCO2 gradient in long procedures. If you have an ABG in situ, you have to be extra vigilant about the complications, likely complications which can happen. And bradycardia is another thing which can happen while inserting the trochar, especially in young healthy adults with high vagal tone, or in older patients who are beta blockers. It happens due to sudden stretching of the peritoneal cavity, and only thing is you have to do is that in most of the cases you have to release the pneumoperitoneum. Of course, you have to go by the AHA algorithm for bradycardia and restart slow inflation once you have settled it at a lower IAP, and position the patient slowly. Don't be in a hurry in that patient. In such situations, you know that the patient has got a high vagal tone. And in most of my long intra-abdominal laparoscopic procedures, I keep an atropine ready on the table. Anyway, you can even load it in a high-risk patients because it's a very cheap medication. So coming to the physiological consequences of pneumoperitoneum, as I said before, you have mechanical and neurohumoral factors, and there is an insult on multiple organ systems, not only on the heart, lungs, in other systems also, like kidney, liver, brain, even in the ophthalmic system also. So usually, as a precautionary measures or safety measures, in most of the lab instruments, the flow gets cut off at the physician set values like 12 or 15 millimeters of mercury. So that's a safety measure. And the carbon dioxide absorbed, because it's easily absorbed in the body, easily buffered by the principal buffer in the body, that's bicarbonate. So the pneumoperitoneum, inflation of the new abdominal cavity with carbon dioxide can raise intra-abdominal pressure, which can increase the systemic vascular resistance and cause diaphragmatic splinting, basal atelectasis, and it can reduce the, initially it can cause an increase in venous return to the right side of the heart because of the, it is known as the biphasic response, because the blood stored in the splanchnic circulation is shunted into the right side of the heart, but consequently a persistent increase in IAP, intra-abdominal pressure, can reduce the venous return because the effect of high systemic vascular pressure will overtake the return of high right atrial pressure. So it also depends on the patient position also, whether the patient is in Trendelenburg position or reverse Trendelenburg position, and the amount of carbon dioxide absorbed and the autonomic response of the individual patient. So if you, this diagram very clearly depicts the intra-abdominal pressure changes and the changes in the cardiac output, right atrial pressure and left atrial pressure. The blue one is the cardiac output. In the initial increase in intra-abdominal pressure, you can see that there is a rise in intra-abdominal pressure, and then there is a fall in, with the initial increase in intra-abdominal pressure, there is a slight increase in cardiac output, then there is a fall in cardiac output. So also the LAP also, left atrial pressure also increases, and then it starts slowly declining. So also the right atrial pressure, consequent to reduced cardiac output, started decreasing. So as you can see in the diagram, the cutoff point is around 15 millimeters of mercury intra-abdominal pressure. So that's the important of this cutoff point. So usually you keep it around 12 to 15. In a healthy young patient, in a more severe patients with the cardiovascular or pulmonary diseases, you have to set it at a lower level. So in the, I'll recap again the induction phase. The induction, you have induction, abdominal insufflation, abdominal desufflation, and recovery phase. And the initial hemodynamic response, when you induce this, SVR is reduced, MAP is reduced, cardiac output is reduced. But with the insufflation, the MAP can increase because, and the SVR can definitely increase. RAP is increased, right atrial pressure is increased because of the shunting of blood into the right side of the heart. But the SVR also is increased, so that balance is cardiac output can be reduced, and it happens in the more or less in the reverse order at the time of deflation and recovery. So the mean arterial pressure, if you recall, is the cardiac output and SPR, and there is overall increase in MAP, mean arterial pressure, because the and the cardiac index can drop as much as 50% in severely compromised patients. And the increase in SVR, systemic vascular resistance, is treated by vasodilating agent or centrally acting alpha-2 agonist, opioids, or direct vasodilating agents like nitroglycerin. And decrease in venous return and cardiac output is attenuated by appropriate IV fluid. In fact, there is a concept of fluid co-loading at the time of induction, just like in spinal anesthesia during just before the insufflation of the carbon dioxide in laparoscopic procedures. So as a precautionary measure, this is important. You have to limit the pneumo time and pressure to the point of adequate visualization, which you have to discuss with the surgeon, especially in a patient with the compromised cardiorespiratory function, and change in position to be cut short to limit the hemodynamic fluctuations. If there is a gross hemodynamic fluctuations, which has to be communicated with the surgeon, and accordingly the position has to be made supine in between. So what about in high-risk patients? In high-risk cardiac patients, you have to have a thorough pre-op evaluation of the cardiac function. And most of the patients for a long procedures usually require intra-arterial line, TE, transesophageal echo, if you have an expertise, and continuous ST segment analysis in prone patients. And in high-risk patients, we can even employ gasless laparoscopy, but I don't have much experience in a gasless laparoscopy. And definitely you have to start the inflation very slowly, other than rushing the carbon dioxide, and keep it lower intra-abdominal pressure. And as I said before, you had to optimize the preload before induction, and patient tilt after insufflation. You insufflate the abdomen supine, see that patient is tolerating it, and the patient is compensating for the hemodynamic fluctuations and increase the intra-abdominal pressure, then only you start tilting the table. And the pulmonary effect is mainly due to there is an increased risk of aspiration, because there is a tilt of intra-abdominal pressure. There is gastric contents can regurgitate into the esophagus, and there is an increased risk of aspiration. So you have to secure the airway, especially when the patient is in Trendelenburg position, especially and in major intra-abdominal procedures. And the diaphragm is pushed upwards, and there is a risk of basal atelectasis. This happens in almost all patients invariably, but is compensated in the postoperative period in healthy patients, but can cause significant in older patients who can have ventilation perfusion mismatch, and the negative effects of basal atelectasis like hypercapnia, cardiac effects and all. And there will be increased intra-abdominal shunting of the blood. So, and in a prone patients, there can be a reduction in thoracopulmonary complications as much as 30 to 50%. So this could be very significant, and controlled mechanical ventilation is a must. And we don't need any further discussion on that, I suppose. And mechanically delivered tidal volume results in high airway pressure, so that you have to adjust the ventilator strategy. We'll come to that. And further exacerbation of negative effects could be there in restrictive lung disease, Trendelenburg position, and in patients with morbid obesity. This is another class of drugs, class of patients coming for laparoscopic procedures, and is a big topic as such. And respiratory dysfunction in less severe, and recovery is quicker after laparoscopy than laparotomy. This is the reason why even with all these handicaps, we still prefer to go for laparoscopic procedures in a patients with cardiorespiratory problem. So up to 15 millimeters of mercury intra-abdominal pressure with a 10 to 20 degree head up or head down position does not significantly modify either physiological dead space or shunt in patients without cardiovascular problems. The problem happens with patients with the cardiovascular disease. Okay. And in patients with the volume depleted. So what are the effects of hypercarbia? You can have tachycardia, hypertension, dysarrhythmias, ventricular arrhythmias, and it can dilate the arterioles directly and depress the myocardium and enhance the sympathetic activity by releasing the catecholamines. And usually the POCO2 will be in equilibrium in the 15 to 30 minutes in a healthy patient. So the reason could be multifactorial, the absorption of carbon dioxide from the impaired pulmonary ventilation, patient position, or in a volume controlled ventilation. So volume controlled ventilation is not a good strategy for patients in major laparoscopic procedures. Patients with the cardiorespiratory problem, ventilatory changes significantly contribute to hypercapnia. So this is the recap of what I have said: the diaphragmatic pulmonary changes, cardiovascular changes, and I will come to splanchnic, renal, and other systems later on. So coming to anesthesia proper, the standard is the endotracheal tube and controlled ventilation, but there are reports of supraglottic airway devices like Procil LMA, and gastric LMA for patients with laparoscopy, and iGel has been employed for minor lap procedures, lap cholecystectomy, appendicectomy. But you need basically good hemodynamic stability, adequate ventilation, and less postoperative airway complications. So the best choice, if I am asked, is endotracheal intubation in a major laparoscopic procedures, especially with positional changes for a prolonged time. So the supraglottic airways you can employ for non-obese patients with a small degree of head-down position. And airway pressure, once you for a long procedures, you have to take, I'm sure most of you must be using it, but you have to ensure it in 20 to 30 centimeters of water in between the procedures, because and expect an increase in head down position. You can increase the head down position with the cuff pressure. And cephaloid movement of carina and the tube can go actually endobronchial, so that any capnograph change, you have to check the and auscultate and confirm. And you can see a decrease in SpO2 and increase in plateau pressure with the endobronchial movement of the tube. So these are two journals recently come out, have shown that actually there are Indian journals who have used the supraglottic airway devices successfully in laparoscopic procedures. So what should be the ventilator strategy? So you need a lower peak airway pressure and greater dynamic lung compliance. So usually the increase in carbon dioxide can be eliminated with the 10 to 25% increase in alveolar ventilation. So the usual strategy is usually like a lung protective strategy of tidal volume of 6 to 8 ml per kilogram body weight with a small PEEP, usually around 5. But the textbooks say that up to 5 to 10 millimeters of mercury PEEP is safe. So there are numerous studies of pressure controlled ventilation improving oxygenation in bariatric surgery and obese patients for laparoscopic surgery compared to volume controlled. And now the most of the anesthesia machines now has got a volume guarded pressure controlled ventilation. And permissive hypercapnia is okay as long as the carbon dioxide insufficiency is present and in healthy patients. And the optimal PEEP, as I said before, is around 5 centimeters of mercury, and it has shown to significantly increase the PaSO2 compared to no PEEP. And a PEEP of 5 to 10 millimeters of mercury and head up position is maybe needed in obese patients. So this is the ventilator strategy I have adopted recently. This is around 6 ml per kg per minute, and slight ET2 slightly high, and respiratory rate I have set, and I have given a small PEEP. So that was for the low flow. I have used a low flow of around 0.8. So most of the time you need a deep intramuscular block, because once the patient comes out of neuromuscular block, the intra-abdominal pressure varies, and the surgeon, in order to for proper visualization, surgeon will increase the gas flow, which can further compensate for the effects of intra-abdominal pressure, like vasolactasis and the venous return. So the higher PCO2 can potentially cause the resumption of spontaneous ventilation towards the during procedure and towards the end. And the higher IAP is required once the patient comes out of relaxant. So you have to monitor the neuromuscular monitor also. So coming to the fluid management, as far as possible, you can incorporate ERAS protocol, like pre-op carb loading, avoidance of prolonged fast, and reduced bowel preparation. That is basically patients should come euvolemic at the time of induction, and correct any pre-existing fluid deficits before induction. The aim is should be for near zero fluid balance, and balanced crystalloid infusions at 1 to 4 ml per kilogram body weight is what is required usually in the intraoperative period. And you can add judicious use of vasopressors during abdominal laparoscopy, where most of the time you may be able to taper off this at the end of procedure. But I should say that intraop fluid assessment with our present tools is extremely difficult. Even the urine output is difficult. The CVP is difficult, or the flow track or Vigilio platform is difficult. The only thing is that if you have a TE, you may assess the LV function directly. So this is what we give for most of our patients. What is prescribed by the RAS Society as per the 2018 guidelines is 800 ml of 12.5 carb load drink night before and 400 ml around 2 hours before surgery. This is the preparation, but I'm not going to promote that preparation. That's what's available here. And it's the complex carbohydrate maltodextrin. And it's the one recommended by the other societies also. It has the advantage is that it has got low osmolarity and clears through the stomach in 90 minutes. Even in diabetic patients, you can give. Only thing is that you have to give it at 3 hours before, and the peak blood sugar level is found to be around after 3 hours. And by the time you take the patient, it will be over. And the advantage is that the patient will feel fresh, he will be euvolemic, and you have enhanced recovery at the end of procedures. Coming to desufflation and recovery period, you have to be very careful at that time, because even with the lap desufflation, minute ventilation requirements can remain high because the carbon dioxide has to be eliminated slowly. And you have to ensure adequate timing for extubation. You don't have to hurry up at that time, especially when the procedure extends around 5 to 6 hours. And this has to be especially careful in patients with the cardiovascular disease. Hemodynamic effect will take time to settle, and you need to extensively monitor the patient in the postoperative period. And transient increase at extubation can be seen because the carbon dioxide in the collapsed capillaries reaches systemic circulation, because the intra-abdominally, most of the capillaries will be compressed due to intra-abdominal pressure. And once it released, because these capillaries may still have a metabolism, and they store the carbon dioxide, and that gets slowly eliminated. And coming to some of the complications which can happen, subcutaneous carbon dioxide, subcutaneous emphysema I have described. And because it happens, I think most of you can appreciate it in the diagram. This is extraperitoneal insufflation. And some of these surgeries like inguinal hernia, renal, and lymphadenopathy, you can see it very commonly. And there are reports that from neck to groin and lower limbs, it has extended the carbon dioxide surgical emphysema. Increase in EtCO2 after stabilization, you should have to be very careful, because most of the parts will be covered under the drapes. And please see that it can happen even without pneumothorax. And usually with the time it resolves, and you can temporarily interrupt the procedure. And if not corrected by ventilation, usually with your ventilation strategy, it will correct and resume with the lower inflation pressure. And there is no contraindication for extubation. And you have to see that it is extubated after correction of the PaCO2 to avoid work of breathing, especially in COPD patients and in long procedures. So what are the risk factors for subcutaneous emphysema, especially in prolonged surgery more than 3.5 hours, when the intra-abdominal pressure is more than 15 millimeters of mercury, and placement of cannula outside the peritoneal cavity. And you have to be very careful when you have the EtCO2 persistently showing more than 50 in spite of your ventilatory effort. And when the surgeon uses more cannula, that means the risk is more. And high gas flows can also cause surgical emphysema. Another complication is carbon dioxide embolism, because any increase in EtCO2 followed by acute decrease, you have to be very careful about the CO2 embolism. It's mainly happens due to accidental intravascular entry, directly injecting the trochar into the intravascular system. And excessive intra-abdominal insufficiency can also another cause. And chance of severe consequence because you are using carbon dioxide is fortunately less, and the lethal dose is more than five times than air because it's readily soluble, and the volume preload actually can diminish the risk of embolism. Another complication is capnothorax, that is carbon dioxide entering from the peritoneal cavity. It can show like increase in airway pressure, PaCO2 and EtCO2. Because the absorption from the pleural cavity will be more than the peritoneal cavity, it usually settles. But the usual mechanism is pleural tears when the procedure is close to diaphragm, when the surgeon is working close to the diaphragm, like a gastric fundoplication. Or in sometimes patients are very prone because they have embryonic remnants, and with increasing intra-abdominal pressure, it usually opens up, and it's usually seen on the right side of the lungs. Yes, it spontaneously resolves in 30 to 60 minutes without thoracocentesis. And if you apply PEEP, it's an alternative option to tube placement. Pneumothorax is another problem, especially when you have a diaphragmatic repair, or when the patient has got emphysematous bullae, which we might have missed in the X-rays. And you can suspect when you have a EtCO2 decreasing with the hemodynamic disturbances and abnormal motion of the hemidiaphragm. And pneumothorax with the rupture of bullae, PEEP should not be applied unlike in capnothorax. So the question is worth taking the risk in pulmonary compromised patients? Yes, the answer is yes, because the positive effect of laparoscopy counterbalance the risk of pneumothorax and inadequate gas exchange in pulmonary compromised patients. And the other thing is that rehabilitation of these patients following laparoscopy and laparotomy makes a big difference in the postoperative period. And some of the other physiological effects is the intracranial effects. It's sometimes overlooked by the perioperative physicians, and this is worsened by the Trendelenburg positions and decreased the venous return from the head and neck, increased the SVR, and there will be cerebral edema. It is compensated, further complicated by hypercapnia, because of it can cause cerebral vasodilation and increase the ICP, and there will be reduced cerebral perfusion and increased intraocular pressure. So it is undesirable to do it in patients with already raised ICP. And can we say, but can we safely done in patients with the ventriculoperitoneal or peritoneal jugular shunts with unidirectional valves? And patients with the glaucoma, you have to be extreme caution. You have to take informed consent in such patients, even though clinically not significant rise is seen. And renal effects, this is very important because there will be increased renal vascular resistance with the rise in intra-abdominal pressure. There will be a decrease in GFR and renal blood flow, and there will be a reduction in urine output, which improves after release of pneumoperitoneum. So that's what I said before, the renal output is not an adequate measure of the fluid balance in the intraoperative period. And that is the challenge for the anesthesiologist also. The pre-existing renal dysfunction or poor dehydration and level of duration of pneumoperitoneum can influence the renal effects. Coming to the hepatic flow, the raised IAP is a vasoconstrictor to the feeding vessels of the liver, and the hypercapnia is vasodilatory. And you can see that there is elevated of liver enzymes and bilirubin in major procedures extending for a long duration. And patients with the severe hepatic failure should probably not be subjected to prolonged laparoscopic procedures because of the concern of further deterioration of the liver function. And the positional injuries, we have to be very careful because most of the time we may not have any access to the patient during procedures, the eyes has to be protected, the pressure points has to be protected, and you have to prevent the overextension of the limbs. If you are keeping it parallel, most of the time we keep it parallel to the body. You have to secure the IV lines properly. You have to, because there is a chance that it can get kinked, and intraoperatively access this will be difficult. And gradual tilting of the operation table, like 10 to 20 degrees at a time, and wait for the hemodynamic changes. Always measure the blood pressure and air entry with every change in position, and check vitals and air entry after position. This is the hemodynamic effects of patient positioning. I have taken Trendelenburg and reverse Trendelenburg position. The effects on, you can see that the effects on right atrial pressure, pulmonary capillary blood pressure, cardiac output, SVR, pulmonary compliance, and pulmonary artery pressure happens in. So there's invariably there is severe effects during Trendelenburg position, reverse Trendelenburg position, and intravascular volume status. And DVT prophylaxis there to be it's something which most of the time is missed. And these patients, especially with pelvic or abdominal malignancy, they are very high risk candidates for deep vein thrombosis. So you have to start measures during the intraoperative period itself. You can have intermittent sequential pneumatic compression during intraoperative period, which can be extended in the postoperative period. Or you can start the pre-op itself, low molecular weight heparin, stop it 12 hours before. But most of the time we do DVT prophylaxis as physical measures, continue it in the postoperative period, and low molecular weight heparin in the postoperative period. And the stomach has to be deflated before trochar placement. That is very important for the anesthesiologist also. So also bladder emptied before pelvic laparoscopy or any prolonged procedure. And maintaining the temperature of the patient is very, very important, and temperature probe has to be there as an by default monitor, and you have to see that patient is actively rewarmed during procedures. And what about the role of nitrous oxide? The problem is that it can combust, support combustion and increase size of accidental embolism and cause distension of bowel, and can contribute to, studies have shown that it can contribute to postoperative nausea and vomiting. And studies have shown that omission improves surgical conditions for intestinal and colonic surgeries. So most of the laparoscopic procedures, we don't use nitrous oxide, and it's almost always oxygen air combination. So what are the minimal monitors? In addition to the ISA standard monitors, you have to use temperature monitors, urine output, cuff pressure, and neuromuscular monitors in selective patients, because you have to detect early warning signs. That is the use of all these monitors. Intra-abdominal pressure and flow, your anesthesiologist has to keep an eye on that, what the technician keeps. And TE is useful, but you need an expertise on the subject. And cardiac output monitors doesn't have much role in the intra when the IAP is very high, but can be used in the pre-op and post-op monitoring. The pain in laparoscopy, usually it is the surgeons will highlight their for the choice as it is pain-free. Yes, it is less painful than the open procedures, especially when you have a rooftop or main long abdominal incision. But you cannot say that it's free of pain, and there will be some discomfort or pain in the first 2 days, which have to be taken care of, and there will be visceral pain like biliary colic, pelvic spasms, or tubal ligation, and shoulder tip pain when because of diaphragmatic irritation, when the surgeon has not deflated the carbon dioxide properly. And you can nowadays to minimize the opioid use and to make the patient street fit at the earliest, we use multimodal analgesia with NSAID, acetaminophen, even xylocaine infusion. We have found that it's a very useful agent in laparoscopic procedures. You give it 1 to 1.5 milligram per kilogram body weight at induction, and continue it at 1 to 1.5 milligram per kilogram body weight per hour in the intraoperative settings for 3 hours, and it used to be a very useful agent. So also magnesium and a subanesthetic dose of ketamine. Dexamethasone, has some studies has shown that dexamethasone, in addition to its anti-emetic and anti-edemic action, it has got analgesic action also. And especially in laparoscopic cholecystectomy, abdominal appendicectomy, we use intraperitoneal insufflation of local anesthetic agents after the just before the removal of the port, like ropivacaine 0.2% 40 ml with or without a magnesium. So we should also know the contraindications for this procedure. Any pre-existing raised intracranial pressure is to be very careful. It's a relative contraindication, and patient may not. If with your evaluation, if you see that the patient may not tolerate the cardiovascular changes of raised IAP and positioning, like the patient has got right-sided failure or biventricular failure, or when the patient is in hypovolemic shock, it's an absolute contraindication for laparoscopic procedure. And in patients with the right to left shunts and in patients with retinal detachment, you have to be extremely careful. And patients with severe congestive heart failure and terminal valvular insufficiency are more prone to develop cardiac complications than in patients with ischemic heart disease patients. So that's the importance of proper examination and evaluation of the cardiovascular system before the procedure. And patients with the right left shunt increased the risk of there is a paradoxical embolism. It's obvious. And to summarize, you need a thorough cardiovascular evaluation before taking up the patient, that I have stressed many times during my lecture. And you have to follow the ERAS protocol as far as possible. Please see that you follow the ERAS protocol. And the physiological and biochemical impact of pneumoperitoneum has to be considered in every patient. What is going to be the position of the patient, and how long the surgeon is going to take up this for this procedure. Everything has to be discussed with the surgeon. And if you are working with the surgeon for a long time, it's the situation is much better. He will send you the patient before surgery, discuss the problems, and discuss the likely change in technique during intraoperative period also. And they monitor the hemodynamic and respiratory parameters, and picking up the early warning signs is very important. You have to be aware of the problems, intraoperative problems, which can likely happen, so that you may be able to strike it during any change in these monitors. And the adverse effects are proportional to intra-abdominal pressure, so that you have to in a patient with the compromised function, you can tell the surgeon to keep it around 10 or 12 or even low. Sometimes the surgeons can carry out the procedure with around 8, but in a healthy patient they can give it around 12 to 15. It's okay. And the thing is that you have to prevent when not possible adequately respond all these complications. And the postoperative benefits of laparoscopy usually is much better than the risk you are taking. And the benefits of laparoscopy balanced against the intraoperative risk, you have to weigh very carefully. Then only you should subject the patient to laparoscopic procedures. So thank you for the patient listening. And I once again thank the office bearers and the senior faculties of the ISA Perindalmanna City branch. Thank you.